Slides. Like, Good afternoon, everybody. I'm Dr. Jayanth. I'm a consultant pediatric neurologist and clinical geneticist at KIMS. So today we'll be discussing another interesting topic, that is prenatal diagnosis of genetic disorders. So this is going to be a quick overview of all the major issues that we face from the gynecologist perspective, as well as and geneticist perspective as well. So we'll start with few basics. We'll start with a few aspects of the basic genetic tests that we are currently using, and also the basis of various genetic disorders that we have, and what are the current available tests available prenatally apart from postnatal tests. We'll be focusing more on the prenatal aspects, and also why is it so important to have the whole picture. The ancillary tests in the family is so important in the diagnosis of the whole disease. Even that will be discussed today, and the prerequisites which are often ignored by clinician before the genetic testing is ordered. So we'll discuss detail about pre-test and post-test concept, which is extremely important. And one last aspect is the most latest one, that is preconception carrier screening. This has come into the clinical use since the last few years. We'll also have a word about that. So overall, broadly classifying genetic disorders can be monogenic or chromosomal. Okay, monogenic is something like a single gene disorder. That means the name itself says there's one single gene which is defective, and that is causing the disease. So monogenic disorders can be a genetic problem which can be based from autosomes or sex chromosomes. So in the autosomal disorders, we have autosomal dominant and recessive. As you all know the basics of that, autosomal recessive will need two deleterious genes. Dominant will need only one deleterious gene. And the same goes with sex chromosomes. And if a large chunk of chromosome has been removed, or there's a deletion or a duplication, so that will all go into chromosomal abnormalities. So we'll have various type of chromosomal abnormalities. So broadly talking about genetic disorders, it can be the monogenic or chromosomal, or it can be uh, a combination of the oligogenic or polygenic is one possibility. So this is a broad classification in monogenic, polygenic, chromosomal disorders, and multifactorial disorders. So you need to know about this multifactorial disorders because the classical example being diabetes or autism spectrum disorder. We can't blame one single gene or a genetic factor for the whole pathogenesis. You need to understand that there is a lot happening after genetics. There is epigenetic mechanisms, there's environmental factors. All of this actually play in the contribution of this disease. So these are called multifactorial diseases. Classical examples are diabetes, hypertension, autism spectrum disorder, cardiac anomalies, even cleft palate and cleft lip can be considered multifactorial. So quickly touching on the structure of the genetic material, if you see nucleus is in the center of the cell, and you have chromosomal material condensed inside the nucleus. And when you actually go into the depth and see the chromosomes, you have 23 pairs of chromosomes. And in that, if you actually go and expand the chromosome, you have the structure of DNA being coiled up to form chromosome. So when you're talking about DNA related problems, so you're talking about monogenic disorders. When you're talking about chromosomal disorders, we are talking about the structural problems in the chromosomes. It can be a structural or a numerical problem. So we'll discuss that in the later slides. So when you compare the incidence of a single gene disorder against chromosomal disorders, you see this is the rough incidence. Chromosomal disorders are also not uncommon. So we have different sets of tests for chromosomal disorders. You see this, the incidence is 1 in 200 births for chromosomal disorders. And in that, trisomies, that is Down syndrome, is 1 in 850. And these are some of the incidences. And WHO actually estimates that 10 out of every 1,000 people are affected with a single gene disorder. That's pretty much high. So I just want to emphasize that. Just one second. Okay. Just give me a minute. Okay, so overall, if you see the incidence of trisomies is pretty high, that is 1 in 200. Then we are looking at structural chromosomal abnormalities and structural chromosomal sex abnormalities. So these are the rough incidences. What I mean to say is that both single gene disorders and chromosomal disorders are pretty common in, incidence. You need to know that looking at one particular disorder, for example, I'm looking at a chromosomal microarray. That means I'm looking at all the chromosomal structural problems. But at the same time, you need to look at single gene disorders as well, because that is also equally important and that is also pretty common. So make sure, one single genetic, it's a common misconception that if one single genetic test is done, that all genetic disorders are ruled out. That is never the rule. You need to know what genetic test you have ordered and what has actually been looked at before you consult the parents. Okay. And what is the impact of these genetic disorders? Why talk a lot about prenatal genetics? Why talk about postnatal genetics? If you see rare disorders per se are rare, but if you see the paradox, rare disorders collectively are not that rare. So the combined incidence of rare disorders is around 1 in 200. So when you put them all together, it's not very uncommon. And most of the genetic disorders have complex diagnosis and complex clinical presentation, and also they have a constant diagnostic odyssey. Now nobody gets the correct diagnosis in time, so they go through a long journey of diagnostic odyssey of a lot of suffering and agony. So there's economic burden, there is psychosocial burden, there's social implications, and there's also morbidity and suffering. And most of the genetic disorders also have decreased lifespan as well. So all these are the major concerns why we are bothered about a rare disease or a rare genetic disorder. Why that is why it's very important that it's better to prevent than deal with that situation. So I've discussed this earlier. This is the structural arrangement of the genetic disorder. This is a very important slide. I want you to understand the very basics of the genetics here. So let's compare the nucleus to a bookshelf. Okay. And in the bookshelf, there are a lot of books. Okay. And these books are compared to chromosomes. All right. So once I'm taking one particular book and opening it, so the pages in that are basically various copies of genes. And in that one single sentence, for example, so this is the chromosome, the nucleus is compared to the bookshelf. I'm taking one book from here. So I'll compare that to the chromosome. And one chromosome is one book. So there are various pages in that book. Okay. And in that various pages, so you'll have a lot of genetic material. So in that each sentence will be one nucleotide, and in that each letter will be one base pair. So this is the rough example of how you compare to understand the genetic material. So chromosome as a book, and each page, and there are sequence changes in the paragraph. That can be a single gene disorder. There can be a small important piece of information which is being deleted, or some misarrangement can be there. So all these will come under your single gene disorders. So broadly, if I know that I'm dealing with a disorder which is probably single gene disorder, so I would choose a test which only looks at the sequence variations. So that is the whole exome sequencing or the next generation sequencing. So in this test, the test does not look at chromosomes, it does not look at chromosomal deletions, it does not look at the chromosomal structure. It only looks in the pages and the words written in the page and the sequences in that. All right. So when compared to a chromosomal disorder, for example, I am suspecting a chromosomal disorder like a Down syndrome, then I wouldn't do next generation sequencing or whole exome sequencing. I would rather look at a test which actually looks at the structure of chromosomes. So I would rather add, order a karyotype, or if I'm thinking it's a small microduplication or a deletion, then I would do a chromosomal microarray. So you need to understand the basis of that genetic disorder you're suspecting, and then order tests accordingly. Okay, so this is one of the example I was talking about. This is the sequence change, what we call. So these are called SNVs, that is single nucleotide variants, or SNP, that is single nucleotide polymorphisms. So that means there is some change in the words or the letters in each page. So that is causing the down effects of that. So basically, that particular gene is not working. So you have downstream effects of that protein not being working, and you have disease because of that. A classical example is cystic fibrosis or any monogenic disorder. Okay, so this is one of the example. For example, if you have a very good recipe of a dish which you like, and if you mess up one of the basic ingredients in that, for example, instead of salt, you're adding sugar. So even though that's a small variation, but the entire outcome of that dish would be changing. So this is an example. If there is one single gene, there are 21,000 genes and significant genes. Even if one single gene is gone, so you must be thinking, why is it a severe disease? So if that particular gene is extremely important, so you'll definitely have the disease. For example, cystic fibrosis, neurofibromatosis, tuberous sclerosis. All these are classical examples of a single gene disorder. One single gene being affected, you'll have the entire phenotype of that disease. So I talked about SNVs. So we use the term copy number variations in chromosomal microarray. So like we used single nucleotide variations in monogenic disorders, in chromosomal deletions and duplications, we use the word copy number variations. So here you hear the CNVs in the chromosomal microarray report, and you talk about SNVs, that is single nucleotide variations or mutations in a whole exome sequencing report. So coming to the incidence, how common are these? Like approximately 2 to 4% of pregnancies are complicated by some significant structural anomalies. So when do we actually think of doing a genetic test? So you have a normal antenatal scan being done, and you see the normal scan of the pregnancy showing some structural anomaly, and then it's picking up some fetal anomaly, then that will go into the attention of a gynecologist and maybe a fetal specialist and a pediatric neurologist and a geneticist. Then you order the genetic test. So universal screening of genetic testing is usually not recommended. We only do screening tests, and specific indications that it says structural anomalies, then we can do genetic testing. So prenatal testing strategy and test selection should be individualized and guided by prenatal imaging, finding some family history. So genetic diagnosis can assist in determining what is a fetal prognosis and inform the prenatal care. For example, decisions, the major decisions including reproductive choice, in vitro therapy, if there's any treatable condition, and also planning for delivery, and also be very vigilant that this child may need immediate neonatal care, and that can potentially decrease the morbidity and mortality of that condition. And also it will give you a definite information about the mechanism of the disease, like is it Mendelian, is it autosomal recessive or dominant, and recurrence risk can also be prognosticated based on that. So when in the context of congenital anomalies, the yield of karyotype is around 30% because chromosomal structural disorders are commoner, and with an additional 6% benefit of yield with chromosomal microarray. For example, if you do a karyotype and CMA, the yield is going to be 36%. And even after this, 50 to 60% of them actually remain underdiagnosed or undiagnosed. We don't know the exact reason for the anomaly. So that is when the horizon of next generation sequencing came, because congenital anomalies can happen because of a single gene disorder as well as a chromosomal disorder. It just doesn't mean that if the chromosomal report is negative, you don't have a genetic basis. We need to look at more answers in it. We need to look at in depth or at a higher resolution. So horizon of the next generation sequencing actually started here in 2017, where we started venturing prenatal next generation sequencing. So exome sequencing may be considered for repeaters with anomalies detected on ultrasound when the standard CMA and karyotype analysis have failed to yield the diagnosis. This is a guideline which is clearly given by the International Society of Prenatal Diagnostic and the ACMG board, where it clearly says that no, you have a fetal anomaly and you have done karyotype and CMA, still don't have answers. We strongly think it's still genetic, then go for exome sequencing, or else it's going to be a very difficult path. We'll be discussing why exome sequencing in every fetal anomaly will be difficult. But if a specific diagnosis is suspected, for example, molecular testing can be suggested for a single gene disorder. For example, in antenatal finding, if there is a specific feature like hemimegalencephaly or a particular single gene disorder you're thinking about, like lissencephaly, then you can actually go for a single gene panel or a whole exome sequencing. So this is what I was talking about. Why do we not venture into prenatal exome sequencing? Because it has a lot of sequences. I mean, legal, ethical consequences, social consequences, and a lot of clinical dilemmas when you do routinely prenatal exome sequencing. That is the reason why we don't usually recommend unless and until it's warranted. So if you do a prenatal exome sequencing, it's like, if you see the picture, this is Pandora's box. And like, if you open the box and after that, you don't actually know what to do with it because you have more problems than before. So without a clear phenotype of the previous affected sibling, never venture into prenatal exome sequencing. For example, a couple has a previously affected child, and that child is passed away, and the child definitely had some genetic disorder. You don't have a clear-cut diagnosis in the previous child, and then now the mother comes to you with a third month situation, or maybe a 15 or 16 week situation, without a clear phenotype of the previous sibling. And this is a very tricky situation. They only come to you once they plan everything and just get pregnant and come to you. It's a very difficult situation for you to deal with. So in this situation, you should not venture into prenatal exome sequencing, because if you find some variant of uncertain significance, again, you'll end up having a lot of confusions whether to terminate or not, or to whether it's disease causing or not. So without a clear phenotype of the current conceptors, for example, if the ultrasound is showing some non-specific anomaly, you can't directly go and do prenatal exome sequencing. So you need to have a clear phenotype of the current fetus conceptors, and then think what is your differential diagnosis, and then go for the exome sequencing. And also without a clear, well-written and explained pretest counseling. So this is extremely important. For example, you find anomaly and you directly advise the test without discussing this with the parents, but the outcome of this would either mean termination or continue the pregnancy. That is, it's also not guaranteed. So it's always better to have a clearly well-written pretest counseling. You need to explain the parents what are the outcomes, what is the percentage of picking a disease in this test. None of these genetic tests are 100% guaranteed that we'll find a cause. So we can't promise them that, do this test, you'll have the answer, you can continue. So you need to tell the likelihood of finding an answer. Okay. And the biggest dilemma that every geneticist or every clinician actually faces is the variant of uncertain significance. So you find a gene which is not normal, but you're not sure whether it's really a variant, a benign variant, or a polymorphism, or actually disease-causing variant. So variant of uncertain significance needs to be looked at with a very thorough clinical correlation, reverse phenotyping. Again, it is a lot of confusion. So better do prenatal exome sequencing with a fixed protocol only when this is indicated. Do not randomly venture into prenatal exome sequencing. Okay, and then coming to the chromosomal disorders like traditional NIPT versus advanced NIPT. So now we have something called a high resolution genome-wide parallel sequencing, that is low pass whole genome. So this also looks at chromosomal disorders. So this is a higher version. It looks at other trisomies. Like the traditional NIPT actually looks at a fixed trisomies, and that is like 13, 18, 21, the common ones, and the sex chromosomes. But the high resolution NIPT actually looks at a lot of other chromosomal aberrations. So quickly about the congenital anomalies, they're isolated or multiple. Isolated, you have malformations, deformations, disruptions, and syndromic associations. I won't go into the details. So here we have a collaborative consensus guidelines on congenital anomalies and to when we need to actually start thinking of doing a genetic test. So guidelines clearly state that head, face, and neck compromise they comprise the required part of the fetal anatomic survey in all pregnant women. When they do a scan, you need to comment on the structural abnormalities in the face. The facial dysmorphism needs to be seen, and the examination is to perform in the second trimester at approximately 18 weeks of gestation. So you need to definitely look at the major elements in the brain, like the lateral ventricles need to be seen with the dimensions of it. Look at the structure of choroid plexus, midline falx, if it's there or not. Look at the cavum, septum pellucidum, cerebellum, cisterna magna. So these are the major things we look at in the scan, and do comment on that. And also give a detailed assessment on cranial biometry, that is the circumferences of the head circumference, the anterior cervical circumference, and also the biparietal diameter needs to be looked at, because these could be early signs of hydrocephalus or microcephaly. So we'll discuss about a few conditions wherein we think that congenital anomalies commonly need to be looked at. For example, this child in the MRI, in the scan, if you see, this child has a non-specific anomaly being reported. In the left, if you see, this is a child with anencephaly. These are the scans of an anencephaly. And in the right, if you see the MRI, the fetal MRI was done, which shows a very significant cystic region in the right middle cerebral artery territory. And there's also the cystic changes are causing cerebral atrophy and asymmetric ventricles. So this is definitely some congenital anomaly which caused this. This could be seen in tubulinopathy and other congenital disorders and genetic disorders. So another example here is a common problem, antenatally diagnosed large Wormian hypoplasia. We see that there's Wormian hypoplasia. The cerebellum looks normal, but there's no wormus. So this is also a common congenital anomaly, which needs further evaluation. There's also megacystern in this. So apart from this, you know that we need to look at other spinal malformations, neural tube defects, and also look for the dimensions of the ventricle, pick up early signs of hydrocephalus. So this child has a bigger ventricular size, so could probably look at hydrocephalus. Again, the dimensions of the ventricles need to be very well looked at to find out there's early signs of hydrocephalus or not, or asymmetric. Also, asymmetric or symmetric also needs to be looked at. So this is one of the child with proboscis. This is a form of holoprosencephaly. This definitely needs genetic. This definitely needs a termination because holoprosencephaly has been clearly been associated with bad prognosis and bad survival. Okay. So these are some of the other genetic causes. I won't go into the details. So this is one of the patient with vein of Galen malformations. This is also very common. If you see, there's a keyhole-like anomaly on the seen on the scan. So these children, you need to counsel them because there is treatment for vein of Galen malformations post-natally. You can actually perform a surgery to treat it, but again, it needs a very extremely complicated surgery. So this needs to be consulted with the parents. So this is a vein of Galen malformation. And this is another interesting case. Initially, this child was referred with a common condition like, asymmetric ventriculomegaly is a very common thing we see in the antenatal reports. The asymmetry needs to be looked at. Also look at the dimensions. If the ventricular size is significantly high, we need to monitor them and also counsel them the chances of hydrocephalus are high and may need a postnatal surgery or VP shunting. But when you have an asymmetric dilatation, which is abnormally diverse. It's very different from. It's not even close to each other. Then you start thinking about other anomalies. When you have a doubt, you just get an MRI. So this is a fetal MRI of a child with suspected asymmetric ventriculomegaly, which usually within the normal dimensions can be advised to have continued pregnancy. But on MRI, we found something very interesting. If you see the left side, the cerebral cortex is actually thicker. The ventricle also is huge, but if you see in contrast, there's actually the ventricle, the cerebral cortex is also very thick. The same thing can be observed with the cortical thickness is also pretty high. And I also see that there's some amount of cerebral cortex in the left side is actually coming to the right. So this is a classical case of hemimegalencephaly. So this has a very poor prognosis in the form of hemiparesis and eventually have intractable refractory epilepsy in the future. So this needs to be consulted with the parents and probably this case has a very bad prognosis, so can eventually they need surgery, that is hemispherectomy. So this case of potential termination. This is the same case of the hemimegalencephaly. We clearly see this side of on the axial image, the cortex is thicker than the right, and it's actually overlapping here. So you see here, the dimension of the ventricle is thicker, and the dimension of the cortex is also thicker. So finally, we spoke about the basis of genetic disorders. We spoke about why we need to do prenatal genetic disorder or prenatal testing, why we have congenital anomalies, how to evaluate congenital anomalies, when do they actually need genetic testing. And we also look at few types of congenital anomalies. And finally, the last topic is basically the new aspect which has recently come, which is called the carrier screening test. So why is this so important? Because autosomal recessive disorders do have a very significant global impact on the prognosis and also the economic burden of the country. So with the history of consanguinity, a higher consanguinity in India, so getting a carrier screening is extremely important to prevent potentially incurable disorders. So when to offer this? Do we offer this to every couple? I would, at this situation, this is not the guideline or a consensus. So we do advise a carrier screening test. So carrier screening test basically includes a preconception sample from both the couple, and we look at autosomal recessive disorders. That is the protocol. So here, do we do it for all people? No. But if there's a strong family history of a genetic disorder in the family, we do it. If there's history of consanguineous marriage, we do it. And either of the couple has some genetic disorder, we definitely do it. And there's a history of multiple pregnancy losses, we do uh, look for both chromosomal and single gene disorders. So we're looking at single gene disorders, we'll definitely want to look at the mother's single genes also. So we'll go for carrier testing in that. And in a particular, this I think this situation is very tricky, and a couple from a particular place or a particular country which is known to have high carrier rate of genetic disorders. So for example, I don't want to name the community in India, but Ashkenaz Jews are very particularly known for autosomal recessive disorders like lysosomal storage disorders, Gaucher's, Niemann-Pick, Alexander's, Canavan are very common in Ashkenaz Jews. So in that Jewish community, I mean, they do offer carrier screening for all the couples there. And also, if you have obvious congenital anomalies, we have already discussed this. So these are the rough indications of when to consider carrier screening. So what is carrier screening? So carrier screening is nothing but next generation based testing, that is whole exome test based test, wherein we look at only genes related to autosomal recessive disorders, and particularly not look at autosomal dominant disorders, because again it become very difficult to interpret. So autosomal recessive disorders, we're looking at both the parents, then you look at the probable cause. If both of the parents are carriers for a common disease, a single disease, then you might actually advise for prenatal testing. Okay. And as I said, the consanguinity is pretty common in India. The cousin marriages, especially in South Asia, is very, very, very prevalent. And even in Pakistan and other countries as well, Asian countries, is very common. So here we have different panels. I mean, we need to, one such protocol is only look for common autosomal recessive disorders. But in India, we look at sickle cell thalassemia and 100 genes, which are very common, which include cystic fibrosis, hypothyroidism, and MLPA for Duchenne muscular dystrophy and spinal muscular atrophy. So you can also look for other genes, and you can also look for 500. It depends on what test, what lab you are ordering for. But basically, carrier screening looks at autosomal recessive disorders. So quickly to overview, antenatal malformations identified on scan are very common problem. What we see, you get a very common uh, patient coming to an obstetrics OPD saying that my scan has some abnormality. So first, look at whether it's isolated or associated with any other anomalies. For example, if you have a unilateral ventricular dilatation, then look at other malformations. Does he have any renal agenesis? Does he have any heart malformation? So is the malformation isolated or associated? It needs to be looked at. And prefer doing advanced imaging techniques. I mean, whenever you have a doubt with the scan saying that there could be a probable cyst, then go for advanced imaging techniques like fetal MRI. And also take advantages of ancillary tests. I mean, like imaging and other blood tests. And you try to narrow down the phenotype of the current anomaly. Then you'll understand what you're dealing with. Then you can order the test accordingly. A detailed family history is definitely important, especially consanguinity for autosomal recessive disorders, miscarriages for chromosomal disorders, and previously affected siblings again for autosomal dominant and recessive disorders, sibling deaths, and symptomatic parents if they're directly there. So it's extremely important to delineate which type of problem you're dealing with. Is it chromosomal or autosomal dominant or autosomal recessive? So detailed family history. Then choose the test appropriately based on your clinical phenotyping. For example, you already have a disease being isolated in the previous pregnancy. Only look for targeted testing like Sanger sequencing. Or currently, if the congenital anomaly looks like a chromosomal disorder, go for chromosomal microarray or karyotyping and karyotyping. Or thirdly, if you feel that the congenital anomaly looks like a single gene disorder, go for whole exome sequencing. Or if you do not have the exact delineation of this, then you have to look in both the angles and probably get a chromosomal microarray and whole exome sequencing. Definitely, you have to do pre-test counseling. So pre-test counseling should be a couple. Both the couple should be there. You need to discuss what tests you're going to order, what are the indications of this test, what are the probable outcomes of this test. And the same thing, after the report is being given, dispatched to the patient, you have to do post-test counseling onto what has come in the report and explain the probable consequences, whether this gene identified is significant or not, or what are the sequences of these consequences. And do consider pre-conception carrier screening as I've described. It is basically a couple screening for autosomal recessive disorders, especially there's a family history or a history of specific disease in that community, or the history of consanguineous marriage, or a previously affected sibling with an unknown disease, so do consider preconception carrier screening in these children, in these couples. Yeah, thank you. So, so